All right, everyone. Hello. Welcome to SWOC, September 13th. This occurred last week, and I used a new software to record it, and we had some technical difficulties. So it wasn't recorded, and I'm having to give you a brief overview. So we're going to go over the slides and the case studies. Unfortunately, you're going to miss all the background conversation. So first of all, here at SWOC, normally we meet every month. And the next 2 months, October, November, we're canceling SWOC. The reason why is there are 2 other opportunities for networking and education in the Seattle area, and we want to support these other educational opportunities rather than compete with them. So the first one is going to be on October 4th, and Andy from Organogenesis, the makers of Apigraph, are bringing their medical science liaison to teach us about wound debridement. Her name is Susan Reed, and Susan was the one that came to SWOC back in June and did a lecture on debridement with a hands-on wet lab. It was fabulous. It was very well received, had a lot of information. So she's coming back again, and we're going to be meeting, or her group is going to be meeting at John Howie's restaurant in Bellevue. And we'll have an hour of lecture about the science behind debridement and what the research shows. And during that time, we'll have our free dinner. And then after that, we'll put away our free dinner, or when we're done with eating, we'll put it all away, and then we'll have a wet lab. Susan used pig's feet last time, and I don't know if we're going to use pig's feet or we're going to use fruit or something like that, but we are going to have the hands-on wet lab. And because SWOC wants to support this educational opportunity, we are collaborating with Organogenesis, and we're going to offer continuing ed for anyone who wants it. It's going to be anywhere from 2 to 3 continuing ed credits for $5 total. So you have 2 options. You can come to the restaurant, enjoy the free meal, and listen to the lecture and do all the hands-on and pay nothing. Or you can come and do all that, pay $5 and get some continuing ed for your certification. You can contact Andy at Organogenesis. His information's at the bottom of the screen. The other option is we're going to send out an evite on their behalf to help figure out who's going to come and not. We got to have a pretty accurate count, so we make sure that we have a good-sized room at the restaurant. So that's October. And then in November, UW is having their annual wound care update at the Linwood Convention Center. Here's the information on the cost. You can get up to 14 contact hours, and there's the website. So, and then of course we never have SWOC in December, but then we'll start up again in January. These are the objectives for those that got continuing ed last week, but we're not doing that. All right, case 1. I got permission from the patient to present her case and use her picture, but I forgot to get permission to put it on YouTube. So instead, I went and found something that was very similar on Reddit. Since it's already out there, it's okay. And this is kind of what it looked like. This patient had a C-section that was planned, uncomplicated. She developed a hematoma and quite a bit of bruising and induration along the incision line. And in this picture, you can see that all the way across the abdomen was bruising, and this is how it was with the patient. In fact, the patient had so much induration that her abdomen had really decompressed quite a bit from having the child, but right over that incision, it was still very lumpy and hard as a rock. So it was, quite strikingly deformed for what we normally see. She still had the staples in, and hopefully you can see my little arrow here, but right where the arrow is, that's where the wound was still open. The rest of it was essentially closed and looked like it was epithelializing along the incision. And oddly enough, like I said, this was not a complicated C-section or pregnancy, no gestational diabetes or steroid usage. And so the first question we asked everyone at the meeting was how they would treat it. We had a couple of different ideas. One was to take her back into the OR, take the staples out, open it up, and clean out all the hematoma. And that's very doable. That's sometimes what we have to do. Another option would be to try to pack that little tiny hole there and put dressings on it and just absorb the drainage as best as it comes out. And then the third option would be to use a disposable negative pressure therapy system. And that's the one that we actually did on the patient. Again, this is a picture from the internet, not from the patient herself. We did a couple things here. We used the PICO to help pull the drainage out and create internal compression by sucking out all that drainage. But then we also had her wear Spanx for compression to try to squish everything together and mobilize all that fluid. And so we started on that. And the next day she called us up and said that the PICO was alarming and the dressing was totally saturated. And she came in and it was full of tea-colored or serosanguinous drainage. We took it off. Unfortunately, the patient's a nurse, so she wasn't too freaked out by all of this. And she was able to push on her belly and really massage it and get out quite a bit of tea-colored drainage out of that little hole. And then we put another PICO dressing on. And then that PICO dressing stayed on for 6 days with good suction and almost no drainage. And during that time, the incision completely healed in that little area. Her abdomen decreased in size. It softened up quite a bit. She still had some lumps, but it had definitely shrunk from the Spanx. We also had her lay on her abdomen as much as possible, based on her tolerance level, to add more compression to that incision. And just looking back at that initial picture, when I first saw her, my thought was, oh, this is going to open up and it's going to be really bad. We've all seen this where you have a huge C-section wound and it just splits open and it's huge. None of that happened with her and she was healed. And actually I saw her today and she's still completely healed. So that was a good thing. So case 2, patient presented with pain in his finger and drainage from the tip of his finger down here where it's kind of looks like there's scab and dried blood. He had erythema and, of course, induration. And when he went to the ED and they, of course, checked his blood levels, his labs, they found that his A1C was above 12%. So they took him to the OR and they debrided him. And this picture shows it really well on the top part of his hand. What is that surface? Dorsal surface of the hand. You can see the tendon on his, not plantar, but the underside of his hand. It is, those 2 wounds go down to the bone and to the tendon in the capsule, and you can see everything. So this is very high risk. And we asked how we treat this. So the big thing, the reason why I wanted to show this case study is that you have to fix the underlying etiology, which we know is infection, but there's even a bigger etiology, and that's the uncontrolled diabetes. As wound nurses, we are supposed to debride and clean and use antimicrobials and all this other stuff and heal the wounds. But first and foremost, we have to fix the underlying cause. When he was in the hospital, they, of course, addressed his diabetes. He was known to be diabetic. He just wasn't controlling it because he didn't think it was all that important. And then he had the spontaneous infection that developed. So, now and then he thought he was going to lose his hand, and at least his finger. So he's very committed to managing his diabetes now. So the first thing we did as wound nurses is we reinforced his diabetic teaching and the medications and talked to him about the importance of managing his sugars, and scared him enough that we think he's going to keep using all of his medications. And then we went for some topicals. We tried serial debridement, of course, to get rid of bioburden and slough and all that stuff. And then because of his diabetes and he lacked a history of cancer, we used to put him on Regranex and Promogran in the wound and then Hydrofera blue. And I'm pretty sure, I don't have the chart open in front of me right now, but I'm pretty sure we actually used iodosorb for the first day or 2 when we saw the patient, just because that's kind of our go-to for grossly infected wounds. This is actually something we discussed in the SWOC meeting, is about which antimicrobial dressings, that of all the antimicrobial dressings, which ones are the strongest and your go-to for an infected wound. And we all agreed that iodosorb and Idoflex is the one that we go to. And then we go to the other ones like the Promogran and the Promogran with silver, but Hydrofera blue or any of those other products after the infection's under control. So we did topicals, and then we put him into a compression garment for his hand. And you can get these online. You can get them at some of the compression stores. I'm pretty sure you can't get this at Martin Medical, but I could be wrong. I know you can get it at Mary Catherine's, and I'm pretty sure you can get them at Shine in Seattle. And then, of course, Amazon. But it's a compression for his hand. And that really brought down the swelling. It also allowed us to give him supply so he could change the dressing at home and put his glove on. And so he'd have fresh dressing every day. And this is after he healed. When he first was in the hospital, he was seen by a plastic surgeon and the hand surgeons, and they all were concerned about the top part of his finger here. They thought they were going to have to use split tissue skin graft or something to pull all that skin together. But since we used the compression glove, it forced the skin together, and he ended up healing. And he also kept his fingernail. He has a little bit, he has some decreased flexion in the tip of his finger, but the rest of his hand works normal. So at this point, he's not going to have any surgery. So that's my 2 case studies. And then I saw this other interesting picture that we normally don't get to see with our patients. This is an older gentleman, I should say, who had neurofibroma of the leg. And he had to have, I believe it was a BKA, a very low BKA that he had years and years ago. And so he's been walking around on a prosthetic the majority of his life. And then about a year ago, they found a new neurofibroma in his femur. And it was high enough up that they had to just take the whole thing off by doing a hip disarticulation. Now, the hip prosthetics that you can see him wearing are very challenging for people to use. It requires a lot of upper body strength, and patients who are older really can't use these. But he's had a prosthetic his whole life, and he's pretty much in shape. He did gain some weight on his belly from everything. When they removed his hip, we did work on healing him, but there really wasn't anything remarkable to talk about. So I didn't include anything on that. But I wanted to show this prosthetic to everyone. It goes from his midline on his front to the midline in the back, and they make the hip part of it by molding his torso. So just like they do a diabetic insole with the foam that you step into, or the molding, the dental goop, I guess you could say, that they use to mold the end of someone's stump. They do the exact same thing and make it customized to him. Now, what was really interesting is how they walk. I've got a video here, and let me explain to you what you'll see, and then I'll play it twice so you can see it. He steps forward with his right foot, and then he kind of pivots his torso to bring the prosthetic forward on the left side, and then he actually kind of sits down into his bucket. And so he's very much up and down, up and down. So let me show you that. Yeah, so particularly here towards the end, you can see him going up and down because he has to actually rest his body into the prosthetic to put all the weight on it. So there you go. A hip prosthetic. We don't see those a whole lot. Okay, and then here are Katie Curtis's slides and her case studies.